So let's look at the physiological changes in pregnancy. We come to the danger signs of pregnancy later. So there are physiological, biochemical, and anatomical changes that occur during pregnancy, and these changes may be systemic or local. Most of the systemic changes return to pre-pregnancy status 6 weeks after delivery. These changes occur during pregnancy to maintain a healthy environment for the fetus without compromising the mother's health, and also prepare for the process of delivery and care of the newborn. So, GI changes for the gastrointestinal tract. So there are nutritional requirements, including vitamins and minerals, and these are increased. So the mother's appetite usually increase. Pregnant women tend to rest more often, conserving energy to enhance fetal nutrition. And there is increased salivation and hypertrophy of gum, which may easily bleed. Gastrointestinal mobility may be reduced due to increased progesterone and decreased hormone to stimulate smooth muscles in the gastrointestinal tract. So the gastric emptying is slowed, and similarly in other parts of the gastrointestinal tract, constipation due to increased water absorption, stomach production of gastric acid decrease, and mucus production is increased, decreasing pH. So due to this, peptic ulcer usually improve or disappear because of these changes during pregnancy. But during the pregnancy, because of the enlarging uterus, heartburn is very common due to gastric reflux, um, gastric reflux from the enlarging uterus, and this slows emptying time and increasing gastric pressure. The anatomical positions of the intestines change because of the enlarging uterus too. The liver, there are no morphological changes, but then there are functional changes. There is decreased plasma protein or albumin and globulin. Globulin is also synthesized by the liver. There is increased serum alkaline phosphatase activity. Gallbladder, the progesterone decreases motility. There is a decreased emptying time of bowel, stasis, and also stone formation or infection could occur. Okay. Progesterone decreases motility, and this in turn leads to a decrease emptying time of bowel, and that may lead to stasis, leading to stone formation or infection. Urinary tract, each kidney increase in length and also in weight. The renal pelvis and ureter dilate and lengthen, so there is an increased urinary stasis, and this increases the risk of infection and stone formation. So the renal pelvis and ureter dilate and lengthens, and there's an increased urinary stasis. Okay, so for the renal function, change occurred due to increased maternal and placental hormones, the ACTH, ADH, cortisol, and several hormones too. There's an increase in plasma volume. So the GFR increase, but the water reabsorption does not. And this leads to an increase in urine glucosuria. It may occur for the bladder. There is it's displaced upward and anteriorly by the enlarging uterus, and due to this, there's an increased pressure leading to urinary frequency and urgency. Hematologically, there's an increase in blood volume, and most striking change. The change occurs until term, and the average increase in volume is about 45 to 50%. The mechanism for increasing the volume of blood is not well understood, although strong related factor during pregnancy may also contribute to this effect, and also as it leads to an increase in water and salt retention. Wherever salt goes, water flows. Okay, so RBC is increased by 33%, and iron need increases because of the increase in red blood cell mass. And this is why iron supplementation is necessary during pregnancy. The BBCs, or the white blood cell counts, usually increase. The platelets and clotting factors also increase in production. For the cardiovascular system, the heart slightly shifts in position due to the enlarging uterus, and also so basically the enlarging uterus presses on the diaphragm and leads to a displacement. It displaces the diaphragm upwards, and that leads to a shift of the apex beat. Cardiac output increase to about 30 to 50% during pregnancy, and the peak is reached at 20 to 24 weeks of gestation, and then remain constant until term. During early pregnancy, the stroke volume is increased by 25 to 30 percent, with heart rate increased by 15%. The blood pressure, systemic blood pressure declines slightly during pregnancy, and there is little change in systolic blood pressure, but diastolic blood pressure decreased by 5 to 10 millimeters mercury. So there is little change in the systolic, but diastolic is decreased by 5 to 10 millimeters mercury from 12 to 26 weeks, and then there's an increase in non-pregnant levels by 10. The venous pressure, there is no change in the upper body, but there is an increase in the lower extremities. Lower extremities enlarge, and there's a decrease in venous return to the heart, and this increases the pressure and results in edema. Okay, let's look at the lungs. Pulmonary changes. So capillary dilatation occurs in the respiratory route, and in the esopharynx, the larynx, trachea, bronchi, and so it makes breathing difficult through the nose. And the large uterus pushes the diaphragm, and the lungs are swollen. Functional respiratory changes include a slight increase in the respiratory rate, so 50% increase in minute ventilation, and also 40% increase in minute tidal volume. There's progressive increase in oxygen consumption, as 15 to 20% above non-pregnant level by term. Okay, so the breast and skin changes. The breast increases in size with enlargement of the nipple and increased vascularity and pigmentation of areola. So skin hyperpigmentation over some parts of the body, the face, the forehead, and the cheek. That's what we call plasma. The abdomen, the subumbilical midline, there's a dark purplish pigmentation of linea alba, which turns into linea nigra. It's traced mainly from the symphysis to the epigastrum. There is also striate gravidarum. Okay, so due to the enlarging abdomen, there is stress on the collagen fibers of the skin due to the effects of ACTH. Okay, let's look at the vagina and the uterus. So the vagina, there's an increase in capacity and the length secondary to hypertrophy of the lining epithelium and also the mausolea. Increased glycogen content in the wall secondary to the effect of estrogen increases vascularity and changes the color to purple, and the fold also increases by 10. The uterus, upper parts of the fundus and the body, the upper part is the fundus and the body changing to the upper uterine segment, the lower part of the cervix and the isthmus changed to the lower uterine segment, and the weight increases from 60 milligrams to 1 kilogram at 10. with a volume 10 mils to 5 liters. So now, so basically that's the physiological changes in pregnancy. Okay, let's look at diagnosis of pregnancy. So pregnancy is mainly diagnosed from the symptoms reported by the woman and signs elicited by us or the healthcare provider. So the signs and symptoms of pregnancy, these signs and symptoms are divided into three: the presumptive, probable, and positive signs. So the presumptive or the possible signs are the early breast changes. There's an increase in size, darkening of the areola, presence of Montgomery tubercles. Okay, amenorrhea in women having a regular cycle without the use of hormonal contraceptives. Also, there is morning sickness and vomiting. Then, bladder irritability, like frequency of nutrition. Quickening, that's a date of first fetal movement felt by the mother and it provides an indication of pregnancy. A primary-gravid feels it around 18 to 20 weeks, while a multi-gravid 14 to 16 weeks. Probable signs of pregnancy: you have the presence of HCG in blood, urine, and also there's uterine growth, Braxton Hicks contractions. There's also ballotment. These are the probable signs of pregnancy. The positive signs: when there's visualization of the uterus by um, ultrasound, ultrasonography. That's 6 weeks of gestation. X-rays are not normally used, but X-rays could detect it after 12 weeks of gestation, and also fetal heart sounds by ultrasound and fetoscope or fetal stethoscope between 20th and 24th weeks of gestation, when there is fetal movement by palpation or visible fetal movement. Okay, so some few disorders of pregnancy: nausea and vomiting. This presents between 4 to 12 weeks of gestation. So hormonal influences are listed as the most likely causes. It usually occurs in the morning, but can occur anytime during the day. It's normally aggravated by smelling of food. In management, you just reassure the mother, you give frequent meals, dry meals, and reduce fatty and fried containing foods, and also rest to help. Okay, let's look at heartburns. This is a burning sensation in the midst of the chest region, and progesterone basically relaxes the cardiac sphincter of the stomach, as I said earlier, and allows for the reflux of gastric contents into the esophagus. The heartburns is mostly troublesome around 30 to 40 weeks gestation because at this stage there's pressure from the growing uterus. Management, you just advise the patient to use more infrequent is to take in more frequent meals and to sleep with more pillows than usual. And for persistence or severe, you give antacid like plain Nugel, longer days. Disorders of pregnancy. Let's look at Pica. Is this a term used when women or mothers crave certain foods of unnatural substances such as coal, soil? The cause is basically unknown, but hormones and changes in metabolism are blamed. They just seek medical advice if the substance craved is potentially harmful to the unborn baby. Constipation. Basically, progesterone, like I said, causes relaxation of the um, sphincters. So there is a decrease in motility. There is decreased peristaltic activity of the gut, and this is also displaced by the growing fetus. Yes, increase the intake of water, fresh fruits, vegetables, or veggies in diet, and exercise is also helpful, especially walking. Normally, there is also backache or lower back pains too. The hormones sometimes soften soften the segments to such a degree that some support is also needed. The management, you advise the mother to sleep on a firm bed and also advise support mechanisms of the back. Fainting in early pregnancy, fainting may be due to vasodilatation occurring under the influence of progesterone because it is a compensatory mechanism. So this is due to as fainting or presyncope or syncope. It's just an influence of the progesterone before an increase in the blood volume, or if there is an increase in the blood volume, it just serves as a compensatory mechanism. And the weight of the uterine contents presses on the weight of the uterine contents basically presses on the inferior vena cava and slows the return of blood to the heart. And when that occurs, the body will just try to compensate by decreasing blood, or basically getting the patient in a vertical form for gravity to act on, for blood to flow to all the parts of the body, importantly the brain. So the management, you just avoid long periods of standing. You sit or lie down when you feel slight dizziness, and also you advise the patient not to lie on her back except during abdominal examination. Other disorders include varicosities. So the progesterone, like I said, it relaxes the smooth muscles of the vein and results in sluggish circulation. So the valves of the dilated vessels becomes insufficient, and varicosities results, and because it occurs in the legs or anus as hemorrhoids and the vulva. The management, you just exercise the calf muscles by rising on the toes. You elevate the leg and rest on the table, support the thighs and legs, avoid constipation, and advise adequate fluid intake. Sanitary pad may also support would support vulval varicosities. Okay, and as we've seen so far, the danger signs of pregnancy. Always remember, if there is vaginal bleeding, you have to move straight to the hospital. Reduce fetal movement, frontal or recurring headaches, sudden swelling or edema, rupture of membranes, premature onset of contractions, and also maternal anxiety. For whatever reasons, you have to move straight to the hospital for emergency procedure to be done.